بسم الله الرحمن الرحيم. السلام عليكم. Dear students, today we will start talking about a new series of neonatal problems. But of course, before going to discuss the problems, we need to start with the first subject, normal full-term newborn. And we need to know the normal characters of the full term in order to be able to screen for a variety of diseases and congenital anomalies and help parents with problems they may perceive with their baby. So we need to know what is meant by neonatal period. In another way, what is the definition of a neonatal period? It is a period from birth until 4 weeks postnatal. In another way, first 28 days of life. And the baby is born between 37 to 42 weeks of gestation. And his body weight is more than 2.5 kg. He cries immediately, establishes independent respiration, and quickly adapts to changed environment. His body temperature is around 37 degrees centigrade, pulse rate between 120 to 160 beats per minute, and respiration normally 40 to 60 breaths per minute, blood pressure 60 to 70 over 31 to 45 millimeter mercury. These are normal vital signs for full-term newborn baby. And when we are talking about newborn, we need to know his prenatal history, natal and postnatal. Prenatal history means history of the mother, maternal information. And in relation to maternal information, we need to know about information about previous children, their gestation, birth weight, and outcome. And also we need to know about family context, whether the partner is stable, what about employment of both parents, whether there is single parent or both parents. And also we need to know about family history of certain diseases. If both parents are relative or not, this is an important subject. And of course, we need to know about the current pregnancy. And we need to know the abnormalities or risk factors that the mother may expose during this pregnancy. And need, of course, to ask the mother about the problem or worries about her baby. Because these maternal informations are needed because there are relevant points in obstetric history related to neonatal problems, because some problems that may occur before delivery may be associated with certain problems. And in the following slides, you can see some examples of this problem, of the relevant point of obstetric history that may lead to neonatal problems. Example, when there is family history of inherited disease, this means this disease may be present in the neonate now. And if both parents are relative, the risk of recessive disorder is also increasing. Another example, maternal infection may be associated with infection later on in the fetus than in the neonate. Examples, rubella, cytomegalovirus, and other numbers of infections. When some investigations done prenatally, like ultrasound, this may be associated with diagnosis of some problems like diaphragmatic hernia or congenital heart disease or spina bifida. And another way of diagnosis prenatally, chromosomal anomalies can be diagnosed by amniocentesis. Also, some points during delivery are associated with neonatal problems. For example, shoulder dystocia associated with fractured clavicle and Erb's palsy. Fetal scalp electrode can be associated with scalp laceration. Long second stage labor can be associated with cupped succidium. Difficult labor can be associated with cephalhematoma. Breech presentation can be associated with congenital dislocation of the hip and bruising of the buttocks. Multiple births, like twins or triplets, can be associated with low birth weight, babies, prematurity, asphyxia also, and maternal diabetes can be associated with risk of macrosomia, neonatal hypoglycemia, respiratory distress syndrome. So these are informations related to baby before delivery, what we call maternal information or information related to delivery. Now, after delivery, we need to hear the first cry, which indicate that the breathing is established. Then we need to assess the baby by what we call it Apgar score at 1 minute and at 5 minutes. The Apgar score will be discussed in more details in the subject of asphyxia. It is consisting of many items like appearance, pulse, grimace, activity, and respiration, and we give degree to each response of the neonate, and from the sum of these grade we can assess the condition of the baby. After establishment of breathing, which is need priority, we need also to assess the weight, feeding, urine, bowel motion, assess respiratory rate, assess temperature, and the baby may need some investigations like blood glucose or total serum bilirubin. And here in this topic or in this slide, there are informations related to normal parameter of the normal full-term neonate. His body weight is between 2.5 to 4 kg. Gestational age is between 37 to 41 or 42 weeks of gestation. OFC head circumference is between 33 to 37 centimeter. Hemoglobin between 15 to 20 gram per deciliter. The time of passing meconium and urination 24 hours. And he need amount of feed ml per kg per day, 50 in first day, 75 in the second day, 90 third day, 120 in fourth day, and 150 ml per kg per day in fifth day of life. This picture is of meconium. It is dark color. After that, when the baby is starting feeding, in the third day of life, this color will be changed to yellowish color. We need to assess gestational age. We should be sure that this baby is full term and has the normal criteria of full term. So we need to examine the neonates from up to down, from the head to heel. And we look to his shape and color to assess presence of cyanosis or plethora. Then we need to look to the face and look to the cranium head for diagnosis of large or small head. The face is very important if he looks of normal facial appearance or abnormality, and need to examine the eyes. Assessment of red reflex by ophthalmoscope is important to assess congenital cataract. This is picture of normal full term. show to us the physical criteria of this newborn. It looks like chubby appearance. It means he has good subcutaneous fat. He has good tone. And this picture shows that he is lying in flexion position, which is normal. And in this position, he is lying, demonstrating to us asymmetric tonic neck reflex. The side, he turned the face toward the head toward one side. There is a flexion in the side opposite to the head, and extension of the side toward the head is turned too. This is called asymmetric tonic neck reflex, which is a normal in full-term newborn baby. Also, he is characterized by prominent of breast, butt, and ear cartilage. This picture is more prominent. This is the nipple. The breast bud is clear, while this is not so clear in preterm baby. This is a preterm baby. When he is lying, there is extension of lower limbs. But in full term, in previous picture, we show flexion of upper and lower limbs. Here is a flexion of upper limbs and extension of lower limbs. Also, he is characterized by small amount of cartilage in the ear and a small breast bud. The details of features of preterm baby will be left to the lecture of prematurity. The full-term baby may be normal, appropriate for gestational age. The normal weight may be large for gestational age. The body is more than expected for his age. Or he may have low birth weight, and we call him small for gestational age. We need to examine or to look to the normal newborn as a whole. This picture shows to us short extremities. This baby has achondroplasia. We need to measure the length and weight and apply to these types of chart. Weight for age, and this is length for age, and this is OFC for age. This picture shows to us how can we measure the length of a newborn baby. This picture shows to us we need to examine everything in the neonate as will be demonstrated in the following paragraphs. First, we look to the skin color because we need to assess whether he has normal pinkish color or he has cyanosed or he has jaundice. A premature baby has skin which is thin, so it is more red and shiny than full term, and he has lanigo hair. These pictures show to us examples of skin abnormalities. Some of them are with the normal variance and some of them are abnormal. This baby is cyanosed, and this cyanosis may be temporary, may be relieved after oxygen, but if the baby has prominent problem, it may persist. This baby has what we call acrocyanosis, peripheral cyanosis. There is cyanosis of hands and feet, and this is normal phenomena first days of life. This newborn, first of all, the skin is covered with a greasy material we call vernix caseosa, which is normal. So show this bag is covered with vernix caseosa, and there is evidence here on the shoulder, immature hair, we call it lanigo hair. This is seen in the newborn, in the preterm newborn baby. And we also need to look for birthmarks which are regarded as normal, like this is Mongolian spot. bluish discoloration of some spots that are present here in the back, sometimes in the abdomen. This is benign. This is Mongolian spot present on the hand. Again, this is not abnormal. This newborn has desquamation of the skin. The skin looks dry and no evidence of vernix. He delivered post-mature, so the vernix is absent. Look to the face of this newborn, looks of yellowish discoloration. He has a neonatal jaundice. This baby has yellowish discoloration of skin and sclera, which is called jaundice. So after looking to the skin and general look, we need to look to the face. In the face, there are eyes, ears, nose, and mouth. So we need to look to these sites. This baby, when we look to his face, we can diagnose him as having Down syndrome. Look to the eye slant, go upwards, and there is a protrusion of the tongue. So this baby has Down syndrome. We need to look to the shape of the face, to the chin. This baby has normal chin, this is clear. But in this picture, on the right side, the size of the chin is so small. This is called micrognathia. We need to look to the eyes, nose, ears, and mouth to discover some abnormalities. This is normal eyes. This is a pupil, and this is conjunctiva. The palpebral fissure is normal. There is evidence of eyelid edema. This is obvious at birth, disappear within days. This is called disconjugate eye movements. Again, it is normal in the early period. This is bleeding subconjunctival hemorrhage due to process of labor. This will disappear later on. Look to the cloudy cornea. This is congenital glaucoma. Look to the cloudy cornea. This is congenital cataract. Again, this is a cloudy cornea, congenital cataract. This is normal ear, obvious. The cartilage, there is amount of cartilage in the ear. This is normal, but we can discover some minor anomaly. This is called ear tag. Again, this is ear tag. This is called accessory auricle. Also, we need to examine in the face. These are areas of whitish material. This is called melia. Also, this is melia, obvious in the nose, and it is a benign lesion, may disappear later on. Sebaceous material accumulated under the skin. After face, we need to examine the head, examine the fontanelle, and the evidence for caput, molding, cephal hematoma, and craniostenosis. So we need to examine anterior fontanelle, posterior fontanelle, and these are called suture lines. This is edema over presenting part, swelling of the presenting part called caput succedaneum, which disappear later on. So this is obvious edema over presenting part. Again, this is caput, and this is called cephal hematoma. The picture shows bilateral involvement by cephal hematoma. Again, this is the same picture, bilateral cephal hematoma. Look to this baby has jaundice because of absorption of the blood that are present in this cephal hematoma. Again, this is cephal hematoma. This is normal nose. We examine also not only the eyes and ears, we need to examine the nose and look to the nasal septum if there is dislocation or not. After that, we need to examine the mouth for cleft palate evidence, and we need to examine the neck for sternomastoid muscle mass. Look to the palate, it is open. This is called cleft palate. This is a cleft lip. This is bilateral cleft lip. This is obvious cleft palate. This is called Epstein pears. This is in the white material in the roof of the mouth, which is normal. Again, there is a retention of this material. They need to look to the tongue, whether normal or ankylosing. See this line. This picture is more obvious. Ankylosing. Sometimes there is evidence of natal teeth. These are teeth called natal teeth. Look to this tooth. Look to these teeth. Then we need to examine the neck for evidence of webbed neck. This is evidence of webbing of the neck that may occur in Turner syndrome. We need to examine the pulses, and if there is evidence of absence of femoral pulses, it means the patient may have coarctation of aorta. So we need to examine the pulse in the hand and in the inguinal region. We need to examine hands for the shape, for creases, for nails, hands and knee and feet of course. And we need to examine the chest. And we will see some pictures about these items of examination. This is called simian crease, single crease. This may occur in Down syndrome. We examine the nails also. These nails are meconium stained. The finger nails stained with meconium. We need to examine the feet. In full-term baby, the creases reach to the end of the foot, while in preterm, the creases are deficient. Also, we need to look for abnormalities of the feet. This picture shows clubbed foot. Again, this is a clubbed foot. Then we examine, after extremities, we need to examine the chest, whether it is symmetrical or not, whether there is dyspnea or not, whether the shape is normal or not. And also we need to examine the heart, calculate the heart rate, which is between 120 and 60 beats per minute. We look for the rhythm and the quality of the heart sound, and if murmur is present or not, in order to do other steps of investigations like X-ray or echo. Look to the chest in this picture. There is evidence of substernal recession. When the baby is taking breathing, there will be recession under the diaphragm. This is called subcostal recession, which indicates presence of respiratory distress. In a neonate, the xiphoid sternum is obvious, as evident in this picture. Then we need to examine the abdomen for palpable masses. In a neonate, we may feel for the liver and kidneys sometimes. We need to look for umbilicus for discharge. We need to look for genitalia which help in assessment of gestational age. We need to look for anus, whether there is patency of anal region or not. Then we need to do examination for congenital dislocation of the hip, examine for feet. Then all the previous steps of examinations or findings are physical. Now we want to assess the neurological system by doing reflexes, neonatal reflexes like moro, grasp, and sucking, and also we need to assess the tone. This is a picture of abdomen, which is cylindrical in shape, and this is umbilical stump. It is white at birth. It has 2 arteries and single veins. This is picture of the artery, like white, full, and this is the picture of vein. And this umbilical cord may be meconium stained. We need to look for genitalia. This is normal genitalia for female. The labia majora cover the labia minora. This is full-term baby. When there is a prematurity, there will be separation of both labii. There may be discharge from urethral meatus, and here there may be vernix also between the labii, which is normal. Regarding genitalia of male, this is the scrotum, is pendulous and pigmented. The testes are palpable in each scrotum, and the urethral opening at the tip of the glans penis. So when the opening is changing in its position, it is abnormal. This is a picture of what we call it infantile menstruation, the withdrawal bleeding. There is vaginal discharge, bloody vaginal discharge after birth, which is normal. This is picture of hypospadias. The urethral meatus is visible on the shaft of the penis, not on the tip. This is abnormal finding. We need to look to the back also, and this swelling is called meningomyelocele. Look to the anus. There is no opening. This is called anal atresia. After doing systemic examination, we need to do growth measures, weight, length, and OFC. We check vital signs. Then we look to the general appearance and start examination of the central nervous system. The position of the baby, inflection position, indicates intactness of the CNS. Not a floppy hypotonic, not extension, it is an inflection position. We need to measure OFC. This is normal position, flexion position. While in this baby has asphyxia, so the color of the skin is changed to pale or cyanosed, and as you look to the head, there is lag of head, severe hypotonia, the baby is floppy. This baby has a neonatal asphyxia. We need to do, after assessment of posture, reflexes, neonatal reflexes, and this is called moro reflex. There is abduction of both arms. This is tonic neck reflex. This is a grasp reflex. This is a stepping reflex. This is again moro reflex. Of course, we need to do these reflexes at the ward, but the pictures can help you in doing these reflexes later on. This is a grasp reflex, rooting reflex, stepping and walking reflex. And so we, at the end, we know the normal criteria of the normal full-term baby, and there are some questions or self-assessment I will send to you in the PDF sample of the lecture, but we will start example of this self-assessment. Match the right state with its correct letter. We have 3 states: consanguineous marriage, shoulder dystocia, maternal diabetes. I will read the normal solution as an example. Of course, consanguineous marriage is associated with increased risk of autosomal recessive disorder like metabolic disease. So number 1 will take B letter. Another state is shoulder dystocia. Shoulder dystocia is associated with fractured clavicle and Erb's palsy. We'll take the letter C. And maternal diabetes is associated with risk of macrosomia, neonatal hypoglycemia, respiratory distress syndrome, and congenital malformation. So we'll take a letter A. Thank you. You will have another examples of this self-assessment I will send to you later on. Thank you.